Hi, everybody. It's Darshak Sanghavi. I am a program manager here at ARPA-H and the program manager responsible for the HEROES program. We're very excited about the HEROES program. As you all know, our solicitation recently went live. And we also recently posted our outcome toolkit as well. For those of you who are interested, we always make sure that you're aware of kind of the three key resources that we have available. Obviously, our program website. You can see the link on our title page here. If you ever are not sure where to go, you can always just literally Google Heroes ARPA-H, and it's really the first thing that'll come up. In addition to that, we also have a direct link here to our solicitation, which is a fancy way of saying the application. That is, in the past, it was the draft. This is now the full solicitation, which is now available for you all. And then finally, we also have our outcomes-based toolkit, which is now available as well. So that allows you to actually draw out the area of your interest, which will then be part of the application or the package that's submitted with the solicitation. And we call that, those will be even it's open now. Those will be due on June 28th. So with that, what I'll do is I'll just let you all know that I'm really pleased to be joined, even if you may not be able to see them, with several of my colleagues on our webinar today. What we'll be doing is this is really a time for people just to ask questions, and we'll go through as many of them as we can. But I'm joined, first of all, by my colleague, Marissa Maloney, who is our contracting officer. She's part of our business innovation division. In short, Marissa, who some of you may have recall if you came to our proposers day, is our expert on all aspects related to our contracting and the person who is really responsible for making sure we follow all the appropriate rules around our solicitation. Really, really depend a ton on Marissa for her incredible knowledge of all these ins and outs. In addition to Marissa, I'm joined by my colleague, Julie Hutchinson, who is one of the primary authors of our draft solicitation. Julie is an experienced health policy veteran who previously worked at the Center for Medicare and Medicaid Innovation, and then for a nationally recognized provider and payer organization as well. Finally, I'm joined by Patricia Yurchik, a registered nurse who is part of our team as well, who is expert in a number of areas on quality improvement and quality measurement, and is really our lead on a number of our data processes as well. And finally, I have my colleague, Yelena Andrianova, who is our business finance manager, who is our budgeting and operations lead for the program. So we'll all be on the call here as well. And I may liberally sort of look to some of our colleagues for help with any of the questions we have. So with that, I'm just going to go ahead and start with the first questions. I'm going to ask my colleague, Julie, it's always nice to see or hear from some of us, to just go ahead and read off the questions in order, and then I will go ahead and answer them to the best of my ability. So Julie, over to you to kind of traffic our questions, and why don't we go ahead and get started?
Sounds great. Thanks. One of the first questions we got was for the ASCVD Veradigm measurement of outcomes. The measurement is showing up where they're getting risk scores at baseline and follow-up for cohort A and cohort B. But for the purpose of evaluating the outcomes and whether the goals are being met, is the calculation averaging numbers from everyone in a given period. And so I guess to say differently, averaging a risk score, whether it's cohort A or B, or whether it's baseline, cohort B, or follow-up. And then I think, Darshak, I would also suggest if people are comfortable and we need clarification, we can also discuss it as well.
Terrific. So I think that in order to answer this question, let me sort of try to give a little bit bigger of an answer that gives even, sort of broader context. And what I want to start with is just fundamentally, how are we going to assess performance in the program? And what we are doing, to be clear, is let's say hypothetically, I am in Washington, D.C., near our operations hubs here. Let's hypothetically say that the ASCVD performer, the health accelerator, is in the greater Washington, D.C., Northern Virginia, Baltimore area. And that's the region of interest. And we've got, say, 700,000 individuals covered by that particular health accelerator that's in the program. So what's going to happen is when the program starts, and that is in 2025, we will look at the national, in other words, across the country, the national average ASCVD risk at the point that the program starts. We'll be calculating that. At the same time, we will look at and to be clear, that's the 10-year risk of heart attack and stroke average for all people aged 40 to 70 for whom we have data. That's the outcome at the national level. Let's say hypothetically, I'm just making this up. Please keep in mind these are illustrative only. Let's say that number is the risk of heart attack and stroke in that population is 9% for 10 years. Then we go ahead and we say, okay, in that area, I'm saying again, for argument's sake only, the Washington, D.C., Virginia, Baltimore area, we have a 10-year risk at that point in time of let's say about 10% as well. So those are the two. What we will do over time is we will adjust the national rate for the same characteristics of what the Baltimore population looks like in terms of sex, age, and ethnicity. That's sort of hypothetically those are our adjustment risk factors. Now, what we do then is when that's adjusted, we will then look at what is that trend over time. So let's say at the country level, in the first 6 months, the average risk score at the country level gets worse by 0.1%. And let's say at the same time, and that compared to their baseline, by the way. In other words, it just increases by 0.1% compared to its own baseline. For the DC, Baltimore, our health accelerator, let's say they do a really good job to get in there. And in that first 6-month period, the risk rate gets better by 0.2% compared to its own baseline. Now, what we see there is, well, the country got 0.1% worse. Our health accelerator got 0.2% better compared to its own baseline. Therefore, the actual improvement compared to the baseline is 0.3%. In other words, 0.2, and then the national baseline got worse, so you get credit for that as well. That is what then would be used to calculate the payment on the rate card. Recall that the target that we're going for to get the maximum payment is about a 1 percentage point reduction. Here, we're actually going to see a 0.3 percentage point reduction. So you get paid whatever 30% of that total amount at that period in time. So I hope that was helpful just in thinking about how we would calculate out the performance. Now the question is, well, what are we doing to actually get that risk score? Well, that's being calculated by and if you ever have questions, our outcome tool calculator, there's all the measure specifications are there, but we are looking at the 10-year risk of heart attack and stroke calculated by the American Heart Association, American College of Cardiology risk calculator called the pooled cohort equation for all you data nerds out there. And then we calculated at baseline, and then we tracked that over time. Using then the longitudinal calculator for what that's worth. The good news is all of these measures are very well specified. It is identical to what was used in the Center for Medicare and Medicaid Innovation Million Hearts Cardiovascular Risk Reduction Model. So we already have experience using this metric for hundreds of thousands of people across the US. And this is a standard that's built into a number of electronic health records as well. The final thing I'll say is, and this is a specific wrinkle within the ASCVD calculator, some organizations have asked, well, look, what if somebody has never gotten care before? In other words, we have a 50-year-old man who has actually not seen a doctor in a long time. And they come into the program, and wow, their initial risk is really high because they've never seen a doctor. They've got high blood pressure, they're smokers, they've got diabetes, and their risk could be 30%. Isn't that a disincentive to enroll somebody like that into the model to start with? In other words, we don't want to look for these people when obviously people are going to do the right thing, but they're worried about that. What we have done is, for purposes of the HEROES model, is that individual would not be part of the calculation until they've had a follow-up visit. In other words, just getting that person care, and if they're high risk, will not hurt the health accelerator. We only will include them once they've had a follow-up visit where something has been done to address that. So I hope that helps a little bit as well. Very long answer to the question that was asked, but I hope that was useful. Julie, should we go on to the next one?
Yep, that sounds great. So the next, this is also a data related question, which Darshak might have answered some of it, but feel free to expand at all if you'd like to. So from this solicitation, we say at the end, from the draft solicitation, we say at the end of each 6-month period of the program, the performance of ARPA-H funded health accelerators will be evaluated and reward payments will be issued proportionally based on the health outcomes that have been achieved. From the April 17th solicitation, the estimated program performance start date is second quarter of 2025. So April 1st, 2025. The first 6-month review would be October 1st, 2025. The Veradigm geographic analysis of 10-year ASCVD risk scores states that each patient will provide at most one follow-up ASCVD risk score for each calendar year following their index year within the follow-up window. Mm-hmm. And only one index ASCVD risk score will represent each patient for the specific time window, in this example year 2025. In the second example table on page 6, they show a patient with visits in January, February, August, and they state that the risk score for this patient will be reported as mid-2025 and using all measures.
Yep. So so let me take a little bit of a step here. So what I'm sensing is that there are a number of complex questions around the ASCVD metric here. Yes. And how are we actually going to calculate these? So one of the things I'd say here is this is probably, to put it out there, let's take a step back for everybody who's listening. We have 4 different metrics. 2 of them are based on emergency medical services data from NEMSIS. That's in near real time. That's our alcohol-related health harm measure and our opioid overdose measure. Then we have our serious obstetrical complication measure. That is a claims-based measure looking at medical claims. Then finally, the ASCVD measure, or the ASCVD, by the way, stands for atherosclerotic cardiovascular disease, or in other words, heart attack and stroke risk. That is an electronic health record-based measure. That's one of the more complicated ones, because we need to actually say, like, what is a person's blood pressure? What medications are they actually on? Do they have diabetes? Are they a smoker? These are sort of a little bit, these all depend, again, on having electronic health record data. Now, one of the really exciting features, or one of the challenges here, is getting all of that data is not an easy thing to do. And so our contractor, at least at this point in time, that is Veradigm, has put together a series of strategies in order to best represent a population-wide risk, and has made some sort of puts and takes on how to best assess that data. What I would suggest here, because this is a very complex question, is for the person or organization that asked this question, if you could please send us an email to the HEROES website, and we'll drop that email address in the chat. and write out that question in a little more detail. What I would suggest is rather than verbally answering something like that, which you kind of, it's just like all these numbers and like, what did he say? I'm getting confused. Rather than that, I think for this one, let's take a beat and write out a really thoughtful response and make sure that the person asking this question hears that, and then we'll post that answer as well, because we want to make sure that we think about this and answer it really appropriately. I hope that was helpful.
Yep. And Darshak, actually, what would be helpful is, so rather than sending your question, a specific question, to the Heroes mailbox, we have a formal Q&A process on our website now that went up with the final solicitation. So if you complete the question through that Q&A, where there's basically drop downs where you can select the category of your question, et cetera, then that will help our team to triage and get you the appropriate response in a timely manner.
Yep, Julie, thanks for that clarification. That's really important. And whoever the questioner is, if you have trouble finding that, please let us know. We'll make sure that you find your way to that area. Thank you.
So I think 1 second. So I would say this same person, there's one other question that is very specific, and it's super helpful that these questions are being asked. So want to also thank those of you submitting this level of detail. It's great to see that you guys are really getting into the weeds of the solicitation. I think that also would be best to submit in the Q&A so that we can draft a formal written response as well, because it's in the weeds of the numbers. Darshak, and then there are also a few questions that we have gone over, or the next question I think that is helpful to discuss is, at what point in the process do the contracts need to be in place with Health Accelerator, consortium organizations, investors, and outcome buyers? I'll also just point to you, Darshak, that I think this really plays into the evaluation criteria when we're assessing, but wanted to give that question.
So as our solicitation has mentioned, one of the key evaluation criteria that we will be looking for, in addition to others, but this is going to be very important, is whether health accelerators are demonstrating the ability to engage their local community as well to supplement ARPA-H in finding matching funds to purchase the outcome. In other words, let's say you are an organization working in a geographic region to reduce the rate of opioid overdoses. As we all know, organizations that are selected for the HEROES program will receive funding from ARPA-H up to $15 million to purchase that outcome. We then want to make sure that program, this is sustainable. ARPA-H, as the analogy we've used, we're like the training wheels for the first 3 years to ensure that this concept of heroes, we sort of get it going. But after the 3 years, we need to ensure that there is that sustainability. As a result, it's critical that our health accelerators do a little bit of networking to try to get other organizations, philanthropy, commercial or public healthcare payers or insurers, potentially employers, or other sources like, say, opioid settlement dollars, to bring those to the table as well. Clarifying, I've said this before, but it's always good to hear it again. ARPA-H is the first $15 million that when a health accelerator is doing a great job, that is all ARPA-H dollars. So nobody else pays anything until those $15 million are exhausted. We de-risk that and take on all the risk at ARPA-H. After that period of time, health accelerators would ideally then have other sources of funds. Now, I want to point out two things as well, and this is very important in the final solicitation compared to the draft. We recognize that asking for a 2-to-1 match, in other words, ideally, this is sort of the aspirational goal, organizations will mobilize about $30 million of capital in their regions to also purchase the outcome. That is a high bar. We get that. And we wanted to be a little more flexible. So we called this out in the final solicitation, but outcome buyers, or those, if an organization works with a philanthropy or payer, we recognize that they may want to pay for an intermediate outcome. something like, for example, ARPA-H, we are paying for lower opioid overdose rates. An organization may choose to say, well, look, we will pay for an improvement in rates of just medication-assisted treatment in this population. In other words, a surrogate or earlier endpoint that implausibly ties to that final outcome, but that's what that payer or philanthropy would like to also pay for. We at ARPA-H believe that those types of funds, if they are promised, does count towards that 2-to-1 match amount. In other words, if an organization finds a philanthropy that says we will be good for up to $10 million to pay for better connection with evidence-based treatment with buprenorphine, that is reasonable for us to count. I want to make sure I point that out. The other piece of the question here is, well, what is the form of that commitment? In other words, like, do we need the money in hand? Can it just be kind of a conversation? Does it have to be a contract? In the solicitation, we've laid out what we think of as a reasonable hierarchy of how we will evaluate the strength of a potential outcome buyer as we think about how close are you to that match. And you can see that in the solicitation. And it ranges from essentially verbal commitment to letter of intent to contract signed to literally having money in the bank. I will say, for purposes of the abstract submission, because I'm calling it the abstract, but solution summary. In other words, the initial response to the final solicitation, those are due on June 28th. We understand that getting money in the door by that point can be extremely challenging. And even, say, for some organizations, like, say, if you're working with a managed care organization or a payer, it's even unrealistic to expect money in the bank by then. Therefore, what we are looking for is just strength of how reassured are we that these are real conversations. And again, that's why we've created that hierarchy. So for purposes of getting through the initial phase, we ask that you do the best job you can to get as strong a commitment as possible. A verbal commitment, potentially letter of interest, a contract. You can think that through in that manner. Having said that, I know this is something we've thought about quite a bit. I want to emphasize the 2-to-1 match is a target. It is not an absolute requirement. So if an organization cannot raise the full $30 million, please don't think that that means you can't apply. In other words, we still want you to apply. Put your best foot forward. We really want us to have sort of a big tent approach here to the extent we can. Having said that, I'm going to pause for a minute and then ask my colleague, Julie, to weigh in if there are any other features related to the solicitation in this regard she should draw attention to. And then I'd also like my colleague, Marissa, to weigh in to ensure that there's nothing else we should mention in terms of the solicitation. Over to you, Julie, for this one.
Thanks, Darshak. No, I think that what Darshak laid out is really the key things to consider from the solicitation perspective. And, I would just pay close attention in the solicitation and the templates that are posted for where you see terms like we will preference certain aspects, right? And so I think that, to Darshak's point, we know that this is a very challenging thing to accomplish in a short time period, especially with the organizations that you might be working with. And so, as Darshak mentioned, it's more about putting your best foot forward, and where there are key things that are called out for preference, I would just make note of that. Marissa, over to you.
I think everything that Darshak and Julie stated is correct and sounds great. When you're looking at the evaluation criteria in the solicitation, just please be mindful of the fact that that is when we're talking about the proposal stage and not the solution summary, or what we were formerly referring to as abstract phase. When you look at the solution summary template, it'll clearly outline what we're looking for at this phase in regards to outcome buyers versus what we're looking for when we get to the proposal phase. And when we get to the proposal phase, that's where you're going to see that sliding scale of the level of commitment and what's of particular importance to ARPA-H when we're evaluating your proposal.
There are two things I want to cover next. Just one, is a follow-up question on this thread, and then I want to go back to Shannon Knapp, who has her hand raised. So for the first question, do the contracts between the Health Accelerators Consortium need to be in place by the abstract or solution summary submission? I'll just answer this briefly, and Marissa, weigh in on anything here. I think, as Darshak, Marissa, and I have mentioned, it's really about putting your best foot forward. And I would direct you to the solution summary template, which specifically outlines the key things that we are asking for in that solution summary that you send in to us. There is a section there that asks for basically to list out the progress that has been made, whether that is the full contract, whether that is letters of interest, letters of intent, et cetera. But all of those details are in the templates and the final solicitation and spelled out in their respective sections. Marissa, would you add anything on that?
No, that all sounds great.
Okay. And then I just saw from Shannon that that we're good on the piece on the previous data questions. So for now, so Darshak, we don't have any new questions, but Marissa and I have been going through and answering some of them in a typing some of the answers as well. So I'm going to reference a couple of those that I think would be good for the benefit of the group. So one question was around whether ARPA-H actively will help connect investors and outcome buyers to health accelerators, and if so, when, in terms of phases. And the key answer that we gave here is that we have a teaming page that we ask everyone to complete. The teaming page is great. It has an entire list of all organizations that have given information with their emails and their focus areas to help connect different organizations together. And Darshak, I also want to give you the opportunity to expand on sort of the work that we're doing there.
Yeah, thank you. So this is such an important part of this process, and I'd like to make sure that we emphasize it, which is that the types of things that Heroes Health Accelerators are trying to do are very difficult. We are trying to improve healthcare or health outcomes and preventive outcomes at a scale that has not really been done before, which is at a whole population level in an accountable manner. That's a really hard thing to do. And we applaud everybody who is even considering participating to improve healthcare in this manner. Having said that, as a result, hard things require coalitions. They require partnership, and they require multiple strategies in order to make impact. In other words, improving opioid overdose rates in a geographic area is a difficult problem. It is likely that organizations may need a few partners, or health accelerators may require a few partners to come together with a number of different strategies to address that issue. And you could say that around all the kinds of challenges that we've chosen as our 4 outcomes. Now, in order to do that, we believe that successful applicants, when you complete what we're calling our solution summaries, will be asked you to explain, well, what are you thinking about? What is your strategy to improve this outcome at scale? And that's like, in other words, what is sort of your thinking? What are your clinical approaches? What are your public health approaches? What are your social and other approaches as well? And what partners have you brought together that should give us confidence that you can actually execute that? So in order to do that, that takes teaming. And so that's one of the reasons why I want to point out it is so critical to register on our teaming page and see who the other organizations are in your region of interest and potentially outreach to them to see, well, are there ways you could work together if that is appropriate? In some cases, it may not be. And there are some places where people will really collaborate. There may be others where there may be some healthy competition. That is all good, but it's through registering on the teaming page that others can actually get a sense of who is available. It is also important because we are working through our investor hub with organizations that are representing potential outcome buyers. In other words, those employers, potentially payers, philanthropy, that are looking for opportunities to invest. So if you register for the teaming page and start to work broadly, that actually then it makes it more attractive so that those outcome buyers are aware. They may not, that once they see that, oh, in this particular region where we have significant philanthropic or business interest, there is a lot of activity. They may outreach to you to say, look, if you pull together a solution summary, we might be willing to offer you an outcome buying contract as well. So that's one of the reasons why it's so important. And so the answer is ARPA-H. So I and my team here, we want everybody to feel that it's a level playing field. So we are not choosing, quote, favorites that we will be connecting with investors and outcome buyers directly. However, we are facilitating circumstances by which we will be connecting organizations that come to us to say there's interest to put them together. And we have several organizations that are literally contracted with our Investor Hub, whose job it is to actually make those connections for organizations that are present on the teaming page. So I hope that's helpful feedback in terms of like trying to emphasize why it's so important at that point, and that help is potentially available as well. And that's true both, by the way, for the outcome buyers as well as for potential investors that might give additional, say, startup or other capital to fund operations while one is waiting to see if they will then get the reward payments as well. Thank you.
Awesome. Thanks, Darshak. The other question, and forgive me if we've already talked about this, but I don't believe that we have, that was posed is whether we will be acting as, or basically speaking towards the initial zero equity $2 million investment that we're using to facilitate the operational implementation, and in the lines of whether we're providing upfront funding. I think the critical thing here is to sort of speak on the nuance of this zero equity investment versus sort of like upfront implementation costs, et cetera.
So this will emphasize this. We recognize that getting started is hard for organizations, particularly ones that are going to be serving areas where these kinds of services may not have existed in the past. There's not a lot of money around. So at ARPA-H, for the health accelerators that are successful and are part of the HEROES program, at that first 6-month checkpoint, all health accelerators will receive a $2 million, essentially $2 million baseline reward payment. In other words, as long as they're part of the program and abiding by the terms and conditions of the program, at that first 6-month checkpoint, regardless of the actual performance, a $2 million payment will be issued by ARPA-H to that health accelerator. And if they in fact have incredible results, the $2 million, that's a floor, then they would actually get an outcome payment even in excess of that. But that $2 million represents a sort of a floor, so that at least some of those dollars will be made available to those health accelerators at that first 6-month checkpoint.
Awesome. Thanks, Darshak. I do not see any new content questions, and we've answered I think we've answered everything else. There's one question that I did see, just for transparency, on whether one is allowed to update the teaming questionnaire and what is the best way to do that. That is something that I'm looking into on the back end, just whether the entry can be updated or whether we have to just submit a new entry. So I'll answer that when I find the answer to that technical question. But Darshak, I don't know if there's anything else that you wanted to expand on. And I'm also looking, and I don't see any hands raised as well. So I think so far we've answered everything.
Terrific. And we recognize that there's a lot of questions that may come up. And one of the reasons, an hour is a long time for people to stay focused. So what we'll do is we're just having frequent ones at these types of seminars, just so people see we're all real people and we're working very hard to respond to the needs and questions coming from our potential performer community out there. So with that, what I'll just do is we'll just wait 30 seconds if anybody else wants to raise a hand or ask a question. If not, we can go ahead and close out for today. It's been a great 40-minute session, and then you'll all be hearing from us about additional sessions as well. I will take just a moment to recommend, for those who have not had a chance to do so, I would strongly recommend you take a look at our outcome mapping tool, which has now been made available. It's what's called our toolkit, and you can see the link at the on the title slide here. If you take a few minutes, I think like it's just time that's well spent as you're thinking about the regions and sort of the geographies in which you'd like to consider putting together a solution summary. So just a quick reminder there. I don't believe we're seeing any hands or questions at this point then. So what I'll do is I will thank you all for your time, your incredible enthusiasm and your questions. And we look forward to our next one of these. Just with that, Yelena or Julie, can you just chime in with when our next couple of scheduled sessions are, if you don't mind, and then we'll close out.
Next one will be on May 9th. The registration is open. So if you think of any questions, please register on our Heroes website.
Okay, thank you all so much. Have a wonderful day. Bye-bye.